Chapter 43, The Child with Gastrointestinal Alteration Continued. Classic signs of gastroesophageal reflux disease includes vomiting or spitting up, hiccuping, and recurrent otitis media. There are two types of GERDs, which include physiologic and pathologic. Box 43.1 outlines the differences. The pathologic form is more serious, and you have to worry about nutritional deficits. They can have frequent respiratory illness as well. Diagnosis is basically made by the signs and symptoms and ruling out other diseases. Also, a feeding diary should be reviewed. In older children, they may measure the pH of the gastric contents and do a barium fluoroscopy. Therapeutic management depends on the severity of the symptoms, but can include dietary changes, position changes, medications, and surgery. Diet will include small, frequent meals with frequent burping as applicable. Avoid caffeine, carbonated, and acidic foods and drinks. Avoid spicy and fatty foods as well. Positioning includes keeping infant under 12 months in the supine position and older than 12 months in the prone position. Medication therapy includes antacids, proton pump inhibitors, and H2 receptor antagonists to decrease acid secretion. Prokinetic agents can be used to accelerate gastric emptying and improve peristalsis. Stomach washing with an NG can be used for acute bleeding episodes. Surgery may be needed for more severe cases. Recurrent abdominal pain, irritable bowel syndrome is not unusual in kids and the cause is unknown. It usually will go away by late adolescence. Stress, emotional events, and infection are believed to be triggers for it. Symptoms include abdominal pain that is unrelated to meals or activity. They can have alternating constipation and diarrhea with undigested foods and mucus present. They will have normal growth as well. Diagnosis is made by ruling out other GI problems. Therapeutic management and nursing care include trying to identify the triggers and removing those triggers. Dietary changes are not needed but encouraged to eat well-balanced diet that's healthy and low in fats. Sometimes an antispasmodic medication may be used. Peppermint oil has also been known to be effective to relax intestinal smooth muscle. Psychosocial assessment should be completed. We need to teach on the healthy diet, reducing triggers, and possibly some family counseling. Manifestations of ulcers in children are burning, cramping, pain when the stomach is emptying. They will many times awaken in the night or early morning with the discomfort. An upper GI with fiber optic endoscopy is a preferred diagnosis method. Medication is the treatment choice for children. A bland diet may help as well, and small frequent feedings. Medications will include antibiotics, proton pump inhibitors, H2 receptor antagonists, and mucosal protective agents. Surgery may be needed for complications that can occur that includes hemorrhage, perforation, or obstruction. Nursing considerations include a thorough history to determine the triggers. Stools and emesis should be assessed for blood. If vomiting is occurring, assess for signs of dehydration. Big focus is on teaching. This can include the patho of the disease, preparing for the diagnostic procedures, education on medications, and the importance of compliance are a few of the important areas. Infectious gastroenteritis is caused by a group of viruses, bacteria, and parasites that cause serious communicable diarrhea, massive fluid and electrolyte imbalance, sepsis, and death. Typically caused by eating a contaminated food or water with a person-to-person contamination. There are various agents that can cause this, and symptoms can vary in severity and length. Having diarrhea will put the child at risk for dehydration and electrolyte imbalance, so you must monitor for each. Therapeutic management would be the correction of these. Oral hydration can be used for many children to replace the fluid loss. Hospitalization is not uncommon, especially for the younger child. Two of the common infections are the rotavirus and C. diff. Rotavirus symptoms include vomiting, diarrhea, low-grade fever, and a history or concurrent respiratory illness. A stool sample will diagnose this. Treatment measures include treating the symptoms, using contact precautions, and there is a rotavirus vaccine that can be in a series as an infant. C. diff manifestations include fever for 24 to 48 hours, diarrhea after antibiotic treatment, diagnosed by blood and polymorphonuclear leukocytes in the stool. Can be treated with a Vanco or Flagyl for 7 to 10 days. Also need to discontinue the antibiotic that caused the diarrhea. Manifestations for an appendicitis is periumbilical abdominal pain that progresses in intensity and localizes to the lower right quadrant at the McBurry point. See figure 43.4. The pain will worsen over time. Some will have nausea and vomiting, anorexia, diarrhea, or constipation, and fever and chills. Careful physical exam can help diagnose. If the appendix ruptures, relief and pain will occur, but then will appear very sickly. WBCs will be assessed in an abdominal ultrasound or CT scan. Surgery is needed to remove the appendix, so nursing care includes keeping that patient NPO, IV access, pain control methods, antibiotics. Surgery is typically done laparoscopic. Education on what to expect and pain relief measures should be provided to the child and to the parent. Inflammatory bowel disease, known as IBD, or chronic inflammatory condition of the small or large intestine, it includes ulcerative colitis and Crohn's disease. Ulcerative colitis involves only the colon and involves both the mucosal and the submucosal layers. Crohn's disease can occur anywhere in the GI tract and involves all layers. Table 43.4 outlines the differences between the two, so please review. A few of the major differences include that Crohn has non-bloody diarrhea and ulcerative colitis has diarrhea with occasional hemorrhage. Crohn has a palpable abdominal mass and ulcerative colitis does not, and severe weight loss is noted with Crohn's disease, where ulcerative colitis has a moderate weight loss. Diagnosis can be made by the symptoms and colonoscopy, rectoscopy, barium enema, and a biopsy. Therapeutic management for IBD includes medication, dietary and symptom management, steroids may be needed, and also the use of Flagyl. Flagyl is your go-to antibiotic for GI. Nutritional support is a major part for both Crohn and ulcerative colitis. TPN may be needed during the flare-ups, and nutrition for ulcerative colitis includes avoidance of milk products, and they have a low-fiber, low-fat diet. Pyloric stenosis occurs when the circular area of muscle surrounding the pylorus hypertrophies and obstructs gastric emptying. The cause is unknown, but muscular hypertrophy is not present at birth. Many times it can be associated with other abdominal abnormalities. Manifestations include projectile, non-bilious vomiting that typically starts after 3 weeks of age. The vomitus can become blood-tinged from irritation. A movable, palpable, firm, olive-shaped mass is felt in the upper right quadrant. You may be able to visualize peristalsis waves right before vomiting. The infant will be irritable and then have course of hungry after eating and vomiting. The infant is at risk for dehydration. Diagnosis is made by symptoms and physical exam, which will include that mass. If it's not able to be visualized, an ultrasound may be needed to confirm. Being sure to ask the parents specific questions on the quantity, quality, and timing of vomiting can help with the diagnosis as well. Therapeutic management includes treating the child for dehydration, if it is present. An NG tube will be placed to decompress the stomach before surgery. Correction of any underlying electrolyte imbalances will be needed prior to surgery as well. Intussusception is the telescoping of a section of the intestine into the distal bowel, causing bowel obstruction. The cause is unknown. Manifestations include issues in an otherwise normal child who is well nourished and no underlying GI abnormalities. Intermittent pain can occur in the beginning and can subside and then again become progressively worse. They may vomit, and the classic symptoms include abdominal pain, passage of blood mucus, which is known as currant jelly, and they can have diarrhea, a sausage-shaped abdominal mass. Symptoms of shock and sepsis can occur 12 to 24 hours if not treated. Abdominal X-ray or ultrasound may be used to confirm the diagnosis. The goal is to return the bowel to the normal position as quickly as possible. If the child does not have symptoms of shock or sepsis, they can use hydrostatic reduction, which will use an isotonic saline or an air enema under fluoroscopy or ultrasound. This is highly successful when used. If it fails or the child shows signs of sepsis or shock, immediate surgery is needed. Many times, corticosteroids are used to prevent a reoccurrence. Celiac disease is the inability for the body to digest gluten. It's considered to be an autoimmune disease. The major manifestations include diarrhea and failure to grow. They typically are below the 25th percentile on the growth charts. Other symptoms include abdominal distension, vomiting, anemia, irritability, muscle weakness, wasting, edema, and is typically not seen until 3 to 6 months after the introduction of the grains in the diet. Diagnosis begins with testing for IgA deficiency. If that is noted, other tests can be conducted as well. A biopsy may be taken, and they will look at how the child reacts when the grains are removed from the diet. Dietary management is the main treatment for celiac disease. Removal of all wheat, rye, barley, and oats need to be eliminated. Many times dietary supplements may be needed. This is a lifelong diet change that is needed. It can be challenging to eat a healthy diet that is gluten-free, but now so many more products are available that it becomes somewhat easier.